So thank you very much, and I must acknowledge the convener of this conference, Swapnil and his team, also the BOS. I greatly acknowledge them. So my topic is on toe walking, which is so I think the program is very well curated. It covers a lot of bread and butter pediatric orthopedics, and we'll start with the simple things. So toe walking is basically a symptom which we see children learn to walk by 12 to 15 months, and by 3 years they develop the heel to toe
Yes,
pattern of walking.
it's me. Audio.
However,
I'll put the audio.
okay. So toe walking is typically seen uh, physiologically as well in about 7 to 20% of children, and most children will begin walking by 12 to 15 months. Usually by age 3 years, the walking pattern of a child develops from heel to toe, and the main culprits are actually the calf muscle, the soleus, and the gastrocnemius, which causes the toe walking. Now, more than half the children which present as physiological toe walkers will stabilize by 5 years. So, by and large, most idiopathic toe walking children, one should wait for any intervention until about age 5. Now, also remember that although the most common cause is idiopathic toe walking, but if a child has got an underlying neuropsychiatric problem, that means either a delayed milestone, almost 40% of them have toe walking. So one must assess these children very early, and most of them are apparent by age 2, whether they've got underlying neurological problems, because the toe walking is very, very high in these children. Other thing which I've seen in practice over the years is if a child has been given a walker at very, very early. For example, this child, the notes mentioned, was walking on his toes at age 3 months, which are hard to believe. But the parents were saying that we gave the child a walker very early. And he started walking without any support at 14 months. Had good eye contact, had no stiffness. So there was no underlying neuro problems. And this child actually presented with a very tight TA. Now, this is what I've seen in practice. If you give a child a walker very early, the calf muscles, the flexors are always overactive. And these muscles then virtually go into something like a spasm, and they get persistent toe walking. Now, the spectrum of toe walking is huge, and what we see in practice, I'll just go through it. Typically, you see children like this, so you may get walking at different ages. These are 20 months, physiological toe walking, 1 year, at 7 years, and at 12 years. All of them have a different diagnosis. So, the one that 1 year, when they start toe walking, you see that the tightness is there as well. So this is a borderline diplegic child. This is a physiological toe walker at 20 months. So the toe walking pattern can present at every age group. And most of the children will have absent heel contact, but they'll walk on the forefoot. So one has to know what is the underlying diagnosis. Is there a need to treat these children? And what is the appropriate treatment? Of course, there are several causes of toe walking. Primarily, one should rule out at least the neurological cause at the beginning. Some of them may present later on. If they were underlying pathology like venous malformations or CMT, they may present later on. But for practical purposes, idiopathic toe walking, CP, tethered cord and all are very important, and even Duchenne muscle dystrophy. So where do we begin with? Of course, history, the history of birth history, the milestone, the development, take a help from your pediatric colleagues, maybe pediatric neurologist, gives you some idea what kind of walking this is. And imaging will help to rule out neurological causes as well. And today we have the facility of doing gait analysis as well. So since we have a gait lab, I'll just share our experience with the gait study as well. The physical examination, of course, will from head to toe, but primarily looking at the muscle tightness in the calf, the knee, and the hip, and also to rule out any limb length discrepancy. The thorough examination of reflexes, tone, will tell us whether the underlying cause is idiopathic or no. And again, if the child can relax the muscle in his sleep, that's a good sign. That means there's no fixed contracture. And these ones usually respond better to at least splinting. Now, sometimes visual analysis is not enough, especially if the toe walking is coming from the neuro point of view, and one has to look the child more in detail. So we have, there's different patterns of toe walking where the child is affected proximally as well. So the hip and knee contraction can also cause toe walking. You can have a dystonic child with the atherotid CP can also toe walk, and you can see how he's actually more stable on his toes. As soon as he comes down, he will lose balance. And sometimes also you get asymmetry. All children may not have bilateral toe walking. They may also have only one side toe walking. So the one has to rule out hemiplegia, or at least a borderline cause which only involves one side of the axis. You can see as like this girl is walking. Yeah. So she's primarily affected on one side, but because one leg goes on the toes, the other one has to go on the toes. You cannot walk with one leg up and one leg down. But typically, with time, they start walking on both sides, but primarily the left side is affected. So there are various classifications of toe walking as well, what has been done based on the analysis. So most of the children will have absent first rocker. So the first rocker basically where there is a heel strike. Because there is no heel strike, they have absent first rocker. And then there's the increased forefoot rocker, which is the third rocker of the ankle. So this is how they have classified toe walking, but I won't go into the details of this. Suffice to say that we do a thorough examination, both static and dynamic. Some of the children will go undergo gait analysis as well, and then we then assess for the treatment. So toe walking, typically any child persisting beyond 2 years, you cannot do a 3D analysis, so we only do a 2D for these young children. For 3D analysis, you need a child to be at least 4 to 5 years of age. The classic example is this one. This child was an idiopathic toe walker, and so you can see that he's got an absent first rocker, so he actually doesn't at all has any dorsiflexion. During the stance phase, there is complete lack of dorsiflexion, and in the swing phase as well, he is unable to get the foot up for clearance, and because of that, he has to hike the pelvis or the hip to clear the flow. So this is a side profile. So these ones are usually a classical graph pattern seen in toe walking children. And you can see what I mentioned earlier. There is increased plantar flexion throughout the stance phase, decreased dorsiflexion in swing phase, and compensatory flexion in the hip and the knee. So the increased flexion around the knee, so that we can enable him to clear the flow. Of course, in cerebral palsy, it's much more obvious clinically as well. So some of the children are subject to gait analysis, like this child with hemiplegia. So you can see the right side is more involved in this child, and the red lines, you see the flexion involvement, knee involvement, and also the ankle. So not necessarily all the equinus comes from the ankle. Because there is proximal deformity as well, one has to assess that with the analysis. And of course, you need to do a clinical examination to decide what is the right treatment for this child. So that's the coronal walking pattern. That is the force plate. So here we get the force data. And then we have asymmetrical patterns in also. This is a child with hemiplegia, which is primarily involved in the left side. And so you can see the left side, again, absent rockers, knee flexion and hip flexion. As far as treatment is concerned, primarily for idiopathic toe walkings, you wait till age 5. Many of them will settle down. You can start doing serial castings, around 3 to 4 years of age if you want. But casting, once you start casting, you must give 2 or 3 plasters, followed by an orthotic. Now, typically, Botox doesn't work so well in the idiopathic group. Mainly, we use it for the cerebral palsy group. And if at all you want to do any surgery for these children, try and reserve surgery till about 8 or 10 years of age. Let the child become mature, get one growth spurt, and surgery has got the best chance of getting a success and the lowest relapse rate. Of course, it's got a set of complications. You don't want to weaken the tendon, so that's why you don't do it very early. Wait till about they're a bit older. And again, you have to decide between lengthening and recession. So in a child who's got idiopathic toe walking, you have to do a lengthening. But in CP children, we never do a TA lengthening. We try and do a calf recession. And many times we can do it now percutaneously with ultrasound control, so we can have much more precision in terms of getting the dorsiflexion, or at least till about 15 degrees dorsiflexion on table. Don't try and overcorrect it, otherwise the calf will be extremely weak. Botulinum toxin we have been using in CP children with great results. It essentially works by giving the injection to trigger points, relaxes the muscle, and then there is complete recovery by 6 months. So we've got some good success with this. But they need to have good splints as well to maintain that heel to toe correction. So just in conclusion, most of the children with idiopathic toe walking will respond to casting and orthotics. Orthotics can be worn full time for at least 2 years, and then you can wean it off. Botox and orthotics is not very effective for the idiopathic toe walking group. If you have to do surgery, decide between recession and lengthening, which will give the lasting benefit. So thank you very much.